Hello, my dear students and critical care trainees and colleagues. The topic of today's discussion would be the oncological emergencies, and I'm going to cover first disease-related emergencies. So, this is a very important topic, very relevant to all clinicians who are working in hospitals' busy area, that is critical care medicine areas and emergency areas. More so, up to 20% of ICU admissions may have an underlying cancer diagnosis. So, cancer patients may present with either as the complications of cancer itself or as the complications of or side effects of cancer therapy during the course of treatment. So, there may be two types of oncological emergencies based on clinical presentation. One is the disease related emergency, and another one is the treatment related emergency. So, in the disease related emergencies, we can have two types again, the mechanical and non-mechanical emergencies. And we are going to discuss today the disease related emergencies mostly. And there can be the side effects of treatment which can present as emergency. And this is an MCQ, important one for all of you to solve it. A 65-year-old man with a diagnosis of small cell lung cancer presents to emergency with complaints of hoarseness, shortness of breath, and swelling of his face and right arm. His vital signs are the temperature 36.4 degrees Celsius, respiratory rate 42 breaths per minute, heart rate of 122, BP of 100 over 67, SpO2 of 87% on 4-liter nasal cannula. On examination, he has respiratory stridor and unable to speak in full sentences. ECG is notable for sinus tachycardia, and a chest X-ray reveals widened mediastinum. What is the most appropriate next step in the management? A. Endotracheal intubation. B. Catheter-based venography. C. CT venography. D. Radiation therapy. Or E. Tracheal stenting. So this is a typical one single best answer type of MCQ, and so the diagnosis is clear here that this patient is a case of SVC syndrome. So this is the first mechanical disease related emergency we are going to discuss today, and which occurs due to complete or partial occlusion of superior vena cava, which is one of the major vein coming out of heart. And most common reason is the external compression by adjacent tumors, most commonly by small cell lung cancer. That is the most common tumor which give rise to SVC syndrome, and the tumors are the most common reason for SVC syndrome. So in tumors, we can have small cell lung cancer, which is the most common cause, and then we can have non-Hodgkin lymphoma, thymoma, mediastinal germ cell tumor, or lymph node enlargement, or any other type of tumor. Okay, which can give rise to STs. But other tumors are quite rare. The most common is small cell lung cancer, followed by non-Hodgkin lymphoma. So many a times, especially in cancer patients, intraluminal obstruction of SVC may occur, okay, which is usually caused by the catheter, long-term catheter like Hickman catheter, and that can induce the thrombosis and which can result in SVC syndrome. Okay, so this is the second most common cause of SVC syndrome, the intraluminal obstruction. And the third common cause, which is quite rare, is the infiltration or invasion by adjacent tube. So the diagnosis is usually clinical, and these patients will come to you mainly with the facial edema, arm edema, neck engorgement, dilated veins on the chest. Airway edema may present with stridor, hoarseness or cough, dyspnea on exertion, orthopnea. And there may be neurological symptoms which may be due to cerebral edema, such as altered mental status and headache. And headache will be very specific. It will be global headache and it will be more on stooping forward. So these are the main clinical features of SPC syndrome, and the diagnosis is mainly clinical. But you need to perform an investigation to see the severity of the ST syndrome. However, clinical features will tell you the severity of ST syndrome and whether it is true emergency or not. But investigations need to be performed, and in that case, chest X-ray is the first initial investigation which will show the media external widening and sometimes bilateral pleural effusion. If it is a case of lymphoma, especially, you will see the bilateral pleural effusion. An imaging of choice would be the CCT, venogram of SVC. So venogram is the investigation of choice, and that will be done to evaluate the degree and cause of obstruction. And to be more precise, you may have to perform MRI for the location of obstruction. So this is all about investigation, the main imaging investigation, apart from the routine ones and ECG, etc., and echocardiography as well. So how will you manage? So management is quite simple. First priority would be to identify the life-threatening symptoms such as the confusion and airway obstruction, and start the supportive therapy such as the elevation of patient's head, oxygen supplementation, BiPAP, and airway intervention would be needed in the form of endotracheal intubation, in which the best option would be to perform an awake fiber optic intubation, because if you manage them with the complete relaxation and sedation, you might lose the airway, and that is the reason we perform awake fiber optic intubation, because tumor might be impinging over the bronchi. Okay, and if it is a long term malignancy for a long time, it might be causing the weakening of the airway wall. So that might lead to tracheomalacia. Even the extubation would be quite challenging in ST syndrome once you have dealt with the primary pathology. And one important thing is to be aware of is that the cannula should be placed in the lower extremity only, and spare the upper extremity, because if the cannula gets dislodged, it would be very difficult to find out whether it is due to cannula or it is due to just upper SVC. So, apart from supportive and emergency management, we need to perform in specific or definitive management, and in that, the endovascular therapy is considered as the first line treatment for SVC syndrome, in which stenting of SVC is done. If you have a central venous catheter, if that is the reason, and if there is a thrombus which is detected, you need to perform the catheter-based thrombolysis or thrombectomy prior to venoplasty and stenting and remove CVC. And regarding the definitive therapy, other form of you have to give the high dose steroid and radiotherapy and systemic chemotherapy depending upon the biopsy results. If the biopsy shows the tumor is sensitive to chemo, then you need to give chemo. If biopsy shows that it is a chemo resistant but radiosensitive tumor, you need to give the radiotherapy as the first line of definitive management. Okay, and sometimes you need to give you need to perform a surgery also. Okay, it is quite rare sometimes, but to do that. So coming back to our question, the MCQ. So what do you think? What could be the best, most appropriate next step in the management of this SPC syndrome? So see, this patient is desaturating and there is a airway threatening condition, airway obstruction. So that is the reason you need to perform endotracheal intubation. So answer is endotracheal intubation. Okay. Fine. So now we will go to the next, we'll move on to next important disease related compressive or mechanical complication, and that is your malignant pericardial effusion, which is a frequent complication of lung cancer, breast cancer, lymphoma, and leukemia. So the main causes of malignant pericardial effusions are the pericardial metastasis, and the side effects. Sometimes it is due to treatment toxicities, okay, which arise due to chemo and radiation therapy. And even infectious pericarditis can also result in malignant pericardial effusion, because these patients are immunosuppressed. So opportunistic infections may be one of the reasons for malignant pericardial effusion. And blockage of lymphatics sometimes may aggravate the size of pericardial effusion. Okay, so the diagnosis is usually clinical. This patient will present. These patients may present with the features of pulmonary edema, an obstructive shock. Okay, the Beck's triad of cardiac tamponade, and there will be pulsus paradoxus, and there will be tachycardia, dyspnea, etc. Features of pulmonary edema, pulmonary congestion will be there. But if you want to do investigation, the first initial investigation would be chest X-ray and ECG. The chest X-ray will show the enlargement of cardiac silhouette and the water bottle appearance, and ECG will show you an electrical alternance of QRS amplitude changing due to sinking heart inside pericardial fluid. Echocardiography is diagnostic, and that will show the right atrial and right ventricular diastolic collapse, because outside there's a lot of fluid, and when heart relaxes it will get compressed by the fluid itself. So that is called diastolic collapse, and which is pathognomic of tamponade physiology. Inferior vena cava, which we intensivists usually perform. So you would see IVC dilatation of more than sometimes 2 centimeter, and there won't be any respiratory variation. So fluid management based on IVC is not a great idea. IVC fails here to tell you anything about the fluid status. So this is the collapse, diastolic collapse, okay, of RV. So that is quite important feature of tamponade physiology. So what are the therapeutic options? So the first important thing you would like to do is the drainage. The drainage of pericardial fluid using the subxiphoid access and echo guidance is the immediate priority, and guidelines recommend leaving the drain in situ, because if you remove the drain, the recurrence rate can be as high as 60%. So that is reaccumulation, right? Quite possible. So to prevent the reaccumulation of pericardial fluid, there are various ways, okay, to prevent it. And important ones are the sclerosing agent or chemotherapy into pericardial space, and pericardiotomy and pericardial window. So these are important ones to prevent the reaccumulation in malignant pericardial effusion, because that is quite common in up to 60% of cases. So we have now another MCQ. A 57-year-old woman with a history of breast cancer treated with mastectomy and radiation therapy is admitted with a 4-week history of progressive low back pain. She reports decreased sensation over her buttocks, perineal region, and posterior superior thighs, and occasional difficulty with voiding. Her physical examination is noticeable for decreased anal sphincter tone. What is the most appropriate next step in the management? So these kind of MCQ might come in any type of exam related to medicine from any board in the world. So the medicine is vast. Every day it is changing, so you have to be thorough with the knowledge. So the options of this MCQ stems are emergent decompressive surgery, CT scan of spine with and without contrast, MRI of full spine, and intravenous dexamethasone. So by now you must have understood that this is the case of malignant spinal cord compression. So that is another compressive oncological emergency which may occur in up to 5% of malignancies, especially in the late stages. Okay, and thoracic spine is the most common site of metastasis and involvement of spine, which can lead to compression. And by the time you see the patient is presenting with the weakness or the autonomic bladder and bowel autonomic dysfunction, the patient spine would be involved at various levels by the tumor. So what are those common tumors which can spread into the vertebra. So that we have to understand, or we should remember. So this is mainly seen in the lung, breast, and the prostate cancers. These are the most common cancers leading to malignant spinal cord compression. So what happens? There is a hematogenous spread of cancer cells to the vertebra where the tumor may grow and impinge on the spinal canal. Furthermore, it may cause pathological fracture. It may cause collapse of the vertebrae with the resultant mass effect over the spinal cord. So that is the pathophysiology. So the diagnosis is usually clinical. New or worsening back pain, the radicular pain will be the initial symptoms. Back pain occurs in up to 95% of patients for up to 2 months before signs related to MSCC appear. But this is not with which patient will come to emergency. They will often come very late in the stages where compression has caused motor weakness, and there will be acute onset paraplegia. Okay, and sometimes you would see autonomic dysfunction of bowel and bladder incontinence, which is a late complication of MSCC. Okay, so that is a bad prognostic sign as well. So what we need to do is to do MRI of full spine within 24 hours of presentation, and that is your imaging study of choice in patients presenting with pain and autonomic dysfunction. CT scan is used for surgery or radiation therapy planning. So MRI is the investigation or imaging investigation of choice, and the answer of this MCQ would be the MRI of full spine, because within 24 patients presenting within 24 hours of the new symptoms, then the MRI has to be performed to plan for decompressive surgery if it is within 48 hours. Okay, so that is your therapy. The initial treatment may consist of high dose dexamethasone, that is your adjunctive therapy. The steroid reduces the vasogenic edema, but remember the definitive management is the thing which changes the prognosis. But that will again depend upon the tumor grade. Okay, and that will depend upon the spine stability and also the onset, the duration of onset of paraplegia. If it is occurring within 48 hours, the acute paraplegia, if it is occurring within 48 hours, then the prognosis is good if you perform a definitive management in the form of surgical decompression. Okay, but for that you need to have a good health status of patient so that he or she can tolerate the surgical decompression, and that is usually followed by the radiation therapy. So now we have another MCQ for you to understand the another compressive or another disease related complication. So this is the case for you. A 54-year-old woman with breast cancer is brought to emergency room with progressive confusion, anorexia, constipation, weight loss, and weakness. Vital signs are temperature of 36.7, BP of 94 over 57, heart rate 87, and SaO2 96% on room air. On examination, she is drowsy but easily arousable and oriented to person. Her neurological examination is otherwise unremarkable. Lab studies are notable for a creatinine level of 1.78 milligram per deciliter. The baseline is zero point 0.8. Definitely it has increased. And the serum calcium of 13.7 milligram per deciliter, which is quite high. What is the most appropriate initial treatment? A, 0.9% normal saline infusion with furosemide. B, 0.9% normal saline infusion. C, bisphosphonate therapy, or D, calcitonin. So it's quite obvious from this MCQ that this is a case of hypercalcemia of malignancy or humoral hypercalcemia, and the symptoms are quite obvious, suggestive of, and this patient is also has high calcium, but it is not too high, 13.7, normal is 9 to 11. So let's discuss this hypercalcemia of malignancy, which is a non-mechanical type of disease-related onco-emergency. It can occur up to 30% of patients with late-stage malignancy. So this is a bad prognostic sign. If patient is presenting with hypercalcemia, that means that patient has already progressed to late stage malignancy or metastatic stage, and they may die within a month of diagnosis. Okay, so that is quite a bad predictor of sign mortality. So what is the etiopathogenesis? Most commonly in up to 80% of cases, PTH, that is parathyroid hormone related protein, which is released from tumor, and that leads to hypercalcemia. And another cases might be there where bony metastasis can induce osteolysis directly from bone tumor, okay, spread, and that can result in hypercalcemia. In case of lymphoma, vitamin D3, that is calcitriol, is produced, which enhances calcium absorption from GI tract and reabsorption from kidneys, so that will lead to hypercalcemia. And in rare cases, it could be ectopic PTH secretion. So the signs are vague. Okay, symptoms are also vague. Hypercalcemia can lead to osmotic diuresis, and that will result in hypovolemia. So such patients will be having severe dehydration once they present to emergency. And in such patients, you may need to perform ECG because hypercalcemia can cause varieties of ECG abnormalities, the arrhythmias, and even cardiac arrest, okay, which can occur at a level of more than 15 milligram per deciliter of total calcium. So, what are the investigations? So to find out the cause of hypercalcemia, so first important thing is the level of calcium. So for that, you need to do a eye calcium, total calcium, and also albumin to find out the corrected calcium. Serum phosphate, magnesium, and potassium has to be done because these are important ions which are low in case of hypercalcemia malignancy. To find out the cause of hypercalcemia, you need to perform parathormone and parathormone related protein levels, and also vitamin D. We got vitamin D, hypervitaminosis of vitamin D can also lead to hypercalcemia. So you need to perform vitamin D level and calcitriol also. And serum electrophoresis should be done to find out the cause like multiple myeloma. ECG should be done, as I said. And remember that in such patient, because of dehydration, acute kidney injury can occur. That is the reason you need to perform the creatinine and urea. And ECG has to be done, which will show the prolonged PR interval and widened QRS complex and shortened QT interval, and also sometimes the blocks. Restoring adequate intravascular volume is the crucial treatment. Okay, so in treatment, the most important, the first line of treatment would be the intravascular hydration, because these patients, due to osmotic diuresis and prolonged hypercalcemia, can have a severe dehydration, and that will lead to AKI. So intravascular hydration is crucial to improve the glomerular filtration rate and prevent further progression to acute kidney injury, and also it can decrease the renal reabsorption of calcium in the proximal tubule. So that is the reason the fluid is the best way to manage hypercalcemia, in which we have to give normal saline as initial bolus 1 to 2 liter, followed by 200 to 500 ml per hour, and rate is adjusted for urine output of 100 to 150 ml per hour. About 30% of patients will improve with intravascular hydration itself. Their calcium level will become normalized. While rehydration, if patient shows signs of volume overload, you need to give loop diuretics. Okay, that is the only indication in case of hypercalcemia of pregnancy or any hypercalcemia due to any reason. Diuretics are not advised until there is signs of volume overload. Okay, like pulmonary edema. So loop diuretics otherwise are not advised as a part of calcium lowering strategy. However, if patient is on thiazides, so that for that you need to see the treatment chart. If patient is on thiazide or lithium or vitamin D supplements, you need to stop them. Okay. Now coming to drug therapy. If you have to, so for in the drug therapy, you need to understand and you need to remember that bisphosphonates are first line drugs. Okay, in bisphosphonate, you can give IV and oral both, but IV is preferred. And IV, we have zoledronate and palmidronate. Okay, so these two drugs can be used. They bind to hydroxyapatite and inhibit bone crystal formation, bone crystal dissolution. Okay, so they bind to hydroxyapatite and inhibit bone crystal dissolution and osteoclastic activity. So this is how bisphosphonate work. But remember that bisphosphonate can cause acute kidney injury. If it is there already, then it can worsen. The bisphosphonates can worsen the acute kidney injury. So you need to hydrate well before you start bisphosphonate. Don't start bisphosphonate in dehydrated patients. You need to start after you have corrected the dehydration. Now another line of management, another drug for hypercalcemia of variancy is the denosumab. So denosumab is a monoclonal antibody that inhibits the rankle receptor and blocks osteoclast formation. So it completely blocks the osteoclast formation. Therefore, it is very effective agent in cases of bisphosphonate resistance. Okay, because there are some cases where bisphosphonate therapy might not work. In such cases, denosumab is the better agent. Now, what about the hydrocortisone? That is your glucocorticoid. So there is a role of glucocorticoid as well, especially in cases where you have a diagnosis like lymphoma or myeloma. So in case of lymphoma or myeloma, what happens is that there is excessive production of vitamin D3. And in such cases where vitamin D3 is produced in excessive form, in excessive amount from lymphoma or myeloma, this steroid will block that. Okay, it depresses the vitamin D3 production from tumor itself. So that is how hydrocortisone would be very helpful. Now another therapy is the calcitonin, but the calcitonin, due to its short duration of action and potential for tachyphylaxis, it is not being used nowadays. And then there are various other agents which I'm not going to talk about because they are not at all used, okay, in ICU. So we are not going to discuss them. But remember, hemodialysis is generally indicated in cases where you find congestive heart failure or severe kidney injury or extreme hypercalcemia of more than 18 milligram per deciliter. These are indications where you need to perform hemodialysis. And as I said, other agents, other drugs, for example, mithramycin is not at all uh, good in such cases where you see the extreme hypercalcemia. So we are not using them. Very limited role. Okay. So what is your answer? The answer is very simple. In this case, the most appropriate initial treatment would be a 0.9% normal saline infusion because this patient has developed AKI already. Right? Now we will move on to next important non-mechanical disease-related emergency, and which is hyperviscosity syndrome. That is also a complication of cancer, and if it is not recognized early and rapidly treated, it may be fatal. So how does it occur? So it occurs in about 15% of Waldenstrom macroglobulinemia of IgM type. That is the most common cause of HVS. Other causes include multiple myeloma and leukemia, hyperleukocytosis, polycythemia, where the platelet count is quite high and leading to hyperviscosity. Even sickle cell disease can lead to hyperviscosity. And sometimes spherocytosis A remarkable amount of erythrocytosis and rheumatoid disease can also result in the hyperviscosity. So hyperviscosity has various reasons, and it results in ultimately hypoperfusion and slow and sluggish blood flow, especially in the peripheries, and resulting in the end organ dysfunction ultimately. So hyperviscosity syndrome leads to a clinical triad. So the diagnosis is usually clinical in such cases. The clinical symptoms of hyperviscosity, the triad is mucosal or skin bleeding and visual disturbances such as the blurred vision, okay, or diplopia, and neurological symptoms might be there like vertigo or hearing loss or paresthesia. So these triads, the skin mucosal bleeding, visual changes, and also the fundoscopic changes and neurological symptoms. So this will lead to this will suggest the hyperviscosity syndrome. But if you want to perform investigation, so remember to do a serum viscosity test if it is available. So there will be evidence of elevated. There will be increased serum viscosity and IgM level would be high. You need to perform complete blood count, peripheral blood smear to look for the abnormal leukocytes and RBCs and platelet count. Okay, and also you need to perform coagulation profile because these patients will be bleeding. Measurement of serum immunoglobulin is not necessary for establishing diagnosis of HVS. The mainstay of treatment are decreasing serum viscosity through plasmapheresis or leukapheresis. If it is antibody which is causing or protein which is causing hyperviscosity syndrome, you need to perform plasmapheresis. And if it is the cell, the WBC, which is leading to hyperviscosity, then you need to perform leukapheresis, especially in cases of leukemia. Multiple sessions will be required, but remember that such cases where you have signs symptoms of hyperviscosity, don't give blood too much. Okay, don't try to correct hemoglobin. Target hemoglobin of 4 to 6 gram per deciliter is enough. Rather, in cases of polycythemia, you need to perform phlebotomy. Okay, and in cases of leukemia, you need to give the urgent chemotherapy to decrease the cell count. Hydroxyurea can be given. So here is another MCQ. I think that is the so this is the MCQ. A 63-year-old man is admitted to ICU with epistaxis, blurred vision, and altered mental status. His medical history includes hypertension, diabetes mellitus, and Waldenstrom microglobulinemia. Vital signs are temperature 37.3 degrees Celsius, heart rate of 102, RR of 44, BP of 112 over 57, SO2 80% on 100% non-rebreathing mask, quite low saturation, and tachypneic. And his physical examination is notable for bloody nostrils, that is epistaxis, and he is somnolent but responsive to verbal stimuli. Laboratory studies are notable for hemoglobin of 9.8 that is wrong, 9.8 gram per deciliter, platelet count of 87,000, and large monoclonal spike on serum protein electrophoresis. So definitely this is a case of some myeloma, okay, multiple myeloma. Which one of the following intervention is not indicated at this time? A. Red blood cell transfusion. B. Plasma exchange. C. Endotracheal intubation. Or D. IV fluid therapy. So answer is quite clear because this is the case of hyperviscosity syndrome. Don't give blood transfusion. Okay. So now we'll move on to another important non-mechanical emergency, and that is hyperleukocytosis and leukostasis. Hyperleukocytosis is defined by a total white blood count, white blood cell count greater than 100 into 10 to the power 9, that is 1 lakh per millimeter cube, whereas leukostasis is defined as or refers to end organ hypoperfusion associated with extreme WBC elevation, that is hyperleukocytosis. The leukostasis is basically a complication, a further stage in hyperleukocytosis where there is a end organ hypoperfusion or shock kind of thing. And leukostasis is more common in patients with AML compared to ALL because in AML the blast size would be larger. So, what is the pathophysiology? So, there are two mechanisms of leukostasis. The first mechanism is the multiplication. Lot of overcrowding occurs and hyperviscosity, and these blast cells clump together, leading to sludging in the microvascular area, and that leads to blockage and decreased flow to the end organs, brain, kidney, and lung, and that will result in the tissue hypoxia, ischemia, infarction, and damage, injury. So this is the first mechanism, common mechanism, how leukostasis can result in an organ damage. There is another mechanism, okay, where the leukemic blast can, adhere to the endothelium because there is a release of inflammatory cytokine and then there is a activation of endothelial cells by the leukemic blast. So both ways there will be adhesive interaction between the blast and endothelium and that will result in microvascular blockage even when the number of leukemic blast is less. So that is another mechanism how leukostasis can result in the end organ damage. So leukostasis may be suspected in presence of multiple organ dysfunction in the form of ARDS, DIC, AKI, and congestive cardiac failure, tumor lysis syndrome, and stroke. So these are various leukostasis related complications you might observe in patients who come to you in emergency department. So therefore, workup should be done in all cases to find out the degree of leukocytosis, hyperleukocytosis, and also the multiple organ dysfunction, how bad patient is, how severe the patient is. CBC with the peripheral blood smear, and in ABG you would see the pseudohypoxemia and pseudohyperkalemia. DIC profile, TLS parameters need to be monitored, and in chest X-ray you would see bilateral interstitial infiltrates, and in CT or MRI brain you would find intracameral hemorrhage. So the aim of treatment would be to reduce the blood viscosity by giving more hydration and also cytoreductive therapy using hydroxyurea and also leukophoresis. So leukophoresis is the treatment of choice in such cases, and remember to avoid a cell transfusion unless symptomatic anemia occurs, and leukophoresis should not be offered in case of acute promyelocytic leukemia APML because of the significant coagulopathy. So leukophoresis is not offered in APML due to increased bleeding chances, and remember to monitor DIC and TLS parameters. This is the last complication which we are going to discuss in the disease related emergency, and that is your severe hyponatremia, which can occur in 50% of hospitalized patients with cancer. And primary cause of severe hyponatremia in such cases would be the SIADH, that is syndrome of inappropriate release of ADH, that is antidiuretic hormone. So in majority of hyponatremic cases, ADH may be secreted inappropriately in response to many stimuli listed here such as chemotherapeutic agents, brain metastasis, and even stress, pain, all can lead to SIADH. Okay. Less commonly, ADH is produced and released ectopically from tumor, particularly small cell lung cancer. Hyponatremic symptoms may be mild and moderately severe depending upon the acuity onset of hyponatremia. If the acuity, the time is very short, the development of hyponatremia is quite short, then the symptom would be severe, even to convergence and coma. Serum osmolality will be lower and urine osmolality will be higher. To rule out other etiologies, perform thyroid and adrenal function test, and don't forget to send the urine sodium. As per recent European guidelines. Management of symptomatic hyponatremia should be done assuming all patients to be chronic hyponatremic, and that is why the correction should be quite slow. The water restriction is the best way. And if you want to start hypertonic saline, give it very slowly to avoid osmotic demyelination syndrome. Otherwise, you can just give some fluid in the form of normal saline, and rather restrict the fluid. But if the patient is dehydrated, definitely normal saline is better than hypertonic saline. And if you are giving hypertonic saline, don't forget to monitor the sodium vigorously, religiously, every 4 to 6 hourly, and the sodium level should not increase by more than 8 millicoulomb over the first 24 hours. The correction should be very, very slow. So we have covered important disease related emergencies, both mechanical and non-mechanical. And in the next video, the next part of this oncological emergency, which we will discuss various treatment related emergencies. Okay, that is going to be quite interesting. I hope this part of oncological emergencies must have given you some important points so that your practice probably would be better if you are hearing to this video. And for more um, videos, please follow my channel on Instagram and YouTube both. And the Instagram handle is at Dr. Saptuke2. Please share this video with all of your friends. So remember to read every day because you are a doctor.